Hi everyone, we are back for episode 3. Is it 3?
4.
No,
3.
yeah, 3. Oh yeah,
should
we should. It's not like we've done 47. So, welcome back. Yeah, episode 3. Thanks again for everyone who interacted last week. And in fact, we have made a Facebook page. So, if you want to go follow us on Facebook, in fact, not follow us, it's like a group.
Like request it.
Yeah, you can request it. Just search for AA Aesthetics on Facebook and we'll start posting up kind of useful information and whatnot in there that you guys will hopefully benefit from, and obviously we'll post our new updates and whatnot in there. We're also on Spotify as well, so if you want to listen to us in the car or on the go, you don't actually want to look at our faces, then you can do that as well. And today I think we're going to cover off vascular occlusion. We're in lots of like groups for different things, and we keep seeing a number of different conversations around vascular occlusion, and a lot of them seem to be either incorrectly diagnosed, because there's a lot of people, aren't there, that constantly say, is this a vascular occlusion? Is this a vascular occlusion? And it's just quite obviously not. So we'll cover off, what will it actually look like, not just the lips but other areas of the face as well, and then also maybe some kind of protocol to actually deal with it, so we can maybe just make people a little bit more aware about what it is, when it happens, and what you can do about it. Yeah. So like I said, in a lot of the groups that we're in, including our own like Eclipse support chat, the thing that people are really scared of when it comes to fillers is obviously a vascular occlusion, because pretty much everything else, let's run through some of the things that can actually happen that are negative. Obviously you can have a negative outcome aesthetically.
With bruising and swelling and things like that.
Yeah, more in terms of like an outcome that you don't like. So maybe you don't like the look of your lips or your cheeks or your nose or whatever the case may be. But it's reversible. So
highlight it.
Yeah, it's not the hugest big deal in the world, although it's very inconvenient for everyone involved, and obviously we would never want to do that. And then the rest of the issues that you can really have, we've got like the basic ones like swelling, bruising, sometimes like some sort of irritation. I've heard of pins and needles as well in certain areas. But again, they're things that are going to go off like fairly quickly. You can get nodules as well, which can be a bit more of a problem. But in reality, the one that people are really concerned about is vascular occlusion, because the results can be terrible.
Yeah, if it goes into necrosis, then obviously there's a problem.
Yeah, so the real concern about vascular occlusion is that you can, if left long enough, it can turn to necrosis, which is where the skin has no supply of oxygen and begins to die, which turns you into quite a large wound essentially, and then scabs, and then can potentially cause scarring. But even more worse than that, I don't think that's the right phrase, is it? Even worse than that, you can also cause blindness, which would obviously be devastating. I believe there's only about 300 cases of that in the world, but none of them that have happened have been able to be reversed as yet. So that's a pretty severe situation. However, when you balance it up to the millions of injections that are being done probably monthly, if not more, then I guess the ratio is not too bad. But you should still be extremely aware of how that can happen, why that would happen, and how to avoid it. Because if you were the actual practitioner where that happened to, it would be pretty much the most traumatic thing that could ever happen to you, I'd imagine. And then even more so, for the client. So
it's life-changing.
Yeah. Most cases are not complete blindness, they are partial, which I'm saying in a way like it's better, which it is better factually, but still absolutely horrific. Yeah. So
they are scary, but there are things we can do. So should we go over the steps of how you could diagnose a VO?
Yeah, how we diagnose it in the first place. So give me an example of some people that we've had on the group chat that have thought that they've had a VO, and why do they think they've had a VO? Give us like a little bit of an explanation.
Yeah, so a lot of the time, it's mainly with lips, really, with our students, isn't it? If they've done a lip and then it's maybe the day after or later on that evening, and sometimes it is actually a fault of the practitioner who's done it and they haven't explained about bruising and swelling. A lot of the time it is just major bruising, and people get confused between bruising and VO a lot of the time.
Yeah, I mean, we've seen some really terrible cases of bruising. In fact, I've sometimes caused it myself, not obviously on purpose, but it can just happen. And I think sometimes excessive bruising, people do just look at it and think, oh my God, it's so bad, it must be something worse than a bruise.
Or a bruise outside of the area. So sometimes you can do a lip and end up having a bruise up here or around there.
Yeah. So, and sometimes as well, it swells so badly, it can make the skin look a little bit more transparent. Mm-hmm. And then I think people are seeing powness. In addition to that, one of the major problems that we have with diagnosing a VO is, do you know what I'm going to say?
No. Capillary refill?
No, is the quality of the photos.
Oh yeah, it's horrendous.
And videos that we get is just literally horrific. People really need to get clear photos and videos, and a lot of the time you'll get someone who will take a picture with their phone, for example, and the lighting's not very good, so the flash goes off
and it just looks like a white, complete white area,
and it looks like a white area, but it's actually just overexposed from the flash, from the photography. So we do need to get good photos. So what are some of the things that we can do, or most importantly the thing we can do to avoid misdiagnosis in the first place?
Are you asking me?
Yeah.
Oh, okay, yeah. I didn't know what you were doing. A cap refill. If we stick with our capillary refill checks that we do and that we teach everyone to do, that's a major one.
Yeah, 100%. So what we teach is, and we've developed this over recent months, whereas we didn't do it in the beginning, is we teach that in each of the 4 quadrants of the lip, before you start your treatment, you should draw a little picture of the lips on your consent form maybe, or a separate piece of paper, hold nice and hard for 5 seconds and take a timing and just write those timings down for each 4 quadrants of the lip. And what that will give you is it will just give you like a baseline as to what they were like before you did it, because I could do a capillary refill check right now on Annie, and it could be like 1 second, and then I could go and do one on Nicole and it could be 4 seconds, and that's before we've put any product in, and even on people that have never had filler before. So it's important to get that baseline reading, because if you do someone's lips and you do a capillary refill and it's coming up fairly slow, 3, 4, 5 seconds for example, you're going to panic, and actually it could have just been like that in the first place. And
on a lot of these group chats that we are on, a lot of the time when these people are panicking, they've taken a video of after the treatment, like regardless of the area, and then they're worrying and saying, is this a slow capillary refill timing? But if you don't have either it written down on the back of a consent form or noted down somewhere with the timings, you won't know, because a lot of the time if you are anxious, you could be questioning yourself, was this quadrant slower than this one, or was this one slower than that one? So either have it written down or video it when you're taking your before photos, but as long as you have that, it will settle that anxiety. And a lot of the time it's one of those things where you're kicking yourself because it's something so simple, so you need to just get it into your routine before every treatment, like putting your gloves on. So it's one of those steps that it can never be forgotten. I would say it's as important really now as putting gloves on, because it's one of those things where you can't, with vascular occlusions, and if we're dealing with the slow capillary refill time in that, as long as like sharp pain, there really are major red flags that we need to be aware of with that paleness. So it's one of those things where it's not a, if you have time, write it down. It's a definite 100%, you can't not do this.
Yeah, exactly. And let's think about it really. If we're going to do 5 seconds per each one of the 4 areas, and try and get your finger slightly over the white area as well, so we can get a feeling for both. And then on your form, you're just going to literally write down the timings. Like 5 times 4 is 20 seconds. And then 5 seconds for each one? You're talking about a maximum of 1 minute to write these things down beforehand. And that's going to give you such a good baseline moving forward to be able to diagnose whether or not someone has actually got some kind of occlusion. So that's definitely the starting point there. And we'd recommend that every single one of you do that before you start your procedure, your treatment, because that's just going to set you up and give you so much more confidence after as to whether a capillary refill time has deteriorated or whether it's actually the same. And although capillary refill is not a 100% guarantee that there is an occlusion, it's a very high % chance that if you are occluded and you're getting a slow refill, that you have got a problem.
Yeah.
So that's a fantastic starting place to do it, and also helps you with that diagnosis as well, because then when you come back, either post-treatment, which is where we say you should definitely do it again, and again write those timings down and make sure there's not too much fluctuation between the two. But also, if your client contacts you, 12 hours later, 24 hours later, 48 hours later, whatever the case may be, and they feel like they've got a problem, they've got some sharp pain, or they've got some powness, they've got some blanching in a certain area, when they send you their capillary refill, you can then compare that to your pre-treatment cap refill and your post-treatment cap refill, and again put yourself in a much better position as to being able to diagnose whether it is a true occlusion or whether it's something else. And actually, with those tiny little small things, you can really give yourself a lot of confidence as to whether or not it is actually an issue. So that's definitely the first place that you should start from your diagnosis, is before you've even started the treatment. So let's talk about if you've gone through your capillary refills, you've got a very high quality video and photos of the area, and it really does look like there is the potential that you've caused an occlusion. Let's first off talk about when this might happen. So the most likely time you're going to see it is immediately after you've done the treatment, and you're going to do your capillary refill check. It's going to refill very slowly, 4, 5, 6 seconds, and you're going to see a powness around the area, a blanching around the area. So when you see that, you are almost guaranteed that you've blocked something. So at that time, obviously you would then start your treatment procedure, which we'll talk about in a minute. However, when you think about the science of it, if you were to inject in a certain area and it does go into an artery, that area of the artery could potentially be quite wide. It could have quite a large volume, and you may be okay. But then over the next period of 12, 24, 48 hours, it moves further along the artery, and arteries always get thinner, obviously, as they get towards like an anastomosis, or they get towards their terminal, their end terminal. And the further it goes up, the more likely you are that that little bit of filler could occlude an artery. So there is the potential that it could happen a period of time later, which again is why it's so important to do all of your pre-treatment, capillary refills, post-treatments, and then have them send you good quality photos and videos should that they think that there's a problem. And I don't know about you, but with my clients, when I go through my post-treatment aftercare form with them, I always tell them that there's certain things that I'm very keen on them following, specifically for hygiene, for example. Don't massage, no ice, no heat, these basic things, no sunbeds. But I also tell them that there's a couple of things that we're looking out for that are very, very important. The first one would be significant sharp pain in an area. The second one would be blanching or whiteness or powness around the area. And the third one would actually be what would look like a bruise, but in a different area to where you've actually done the treatment, which we'll come back to a little bit later on. And I tell them that if they see any of those things, they need to contact me immediately, and I would literally go and see them straight away, or I'd have them come and see me. There's no time to delay in that particular situation. So let's talk a little bit about what our procedure is should we actually think that we're almost guaranteed a vascular occlusion. So
high laser is always going to be like our last option, isn't it? That's going to be, we don't want to just jump straight to that.
No, personally I'd like to, I think if it's right there at the time and you've just done it, I would like to start off with
heat pack, massage.
Yeah, massage 100%, and also aspirin, and make sure that they chew the aspirin and they don't just swallow it, so we can get that working nice and quickly. We don't really want to be waiting 30, 45 minutes for aspirin to kick in. We want it to work straight away. So have them chew the aspirin. You can also give them Viagra as well, which will increase blood flow throughout the system. And I would start off with a little routine of just heat pack, massage, for maybe the first sort of 15, 20, 25, 30 minutes, something like that. If you see absolutely no improvement in that whatsoever, then we're going to look to add Hyalase into our algorithm for treatment. So the reason I say don't start immediately with Hyalase is just because obviously you've just made them potentially look quite nice. You've improved a certain area of their face, usually lips, and to just instantly get rid of them is going to be annoying for you, costly for you. It's also going to mean that the client is going to have a bad result because you're going to remove all of her lips. If she's had filler before, she's literally going to go back to nothing. So give it sort of 15 minutes to 30 minutes first of all to see if you can resolve the issue another way. And the reason we say heat pack, massage and aspirin is because if you have a small tube, i.e. some kind of vascular vessel, by adding heat you reduce the viscosity of the filler, which means that it may flow more easily and disperse. And the massage also, again, if you have like a blocked straw or a blocked tube of some description, you tend to try and crunch it around to get rid of the blockage. So that will help as well. And then the aspirin will just make the blood thinner to maybe potentially pass through it and start trying to clear that blockage. So that would definitely be the first part of the approach to treating a vascular occlusion. If you're definitely not noticing any improvement whatsoever inside that 30-minute period, the next thing that we need to do is we're going to need to start applying hyaluronidase or Hyalase. So the way that I would personally do it is I would mix up my 1500 units of my 1500 IUs or international units of hyaluronidase with 2.5 millilitres of bacteriostatic water. And I would start injecting at all different levels in all different techniques around the area or the place that we have got some clear blanching. Once I'd injected that, I would go back again, heat pack, massage, heat pack, massage. Now, with hyaluronidase, it does have a half-life, and the half-life of hyaluronidase is 1 hour. So in 1 hour, it's effectively going to begin to stop working. So how often do we repeat? It would be a minimum of 1 hour. Sorry, not a minimum, a maximum of 1 hour, because after that point it's really going to start to become significantly less effective. So my personal routine would be that between every 15 and 20 minutes we repeat the same protocol over and over and over and over again. And you may need multiple vials of hyaluronidase in stock, so just having one little bottle in the fridge is really not going to be enough should you potentially have a problem. And in fact, the least amount that I've ever heard of getting rid of a vascular occlusion in the lip has been 7 vials, and I've heard a maximum of 14, but these are only of the ones that I know of. So having 1 vial is definitely not enough.
No.
You're going to need to repeat the algorithm over and over and over again, and that is basically 2.5 millilitres of bacteriostatic water per 1500 IUs. Saturate the area in multiple different planes of the skin and the tissue, in multiple different techniques. You don't actually have to get the hyaluronidase into the vessel that is blocked. It will pass through the walls of the artery and be able to still get rid of it. So you don't have to necessarily aim specifically for the artery that you feel is occluded, because trying to find that again is probably going to be next to impossible. The fact you've hit it in the first place is very unlucky. So to try and hit it again is next to impossible. So you're going to want to saturate the area. Once you've done that, you're going to heat pack, massage, heat pack, massage. We've already given them Viagra. We've already given them aspirin, which they've chewed. So that's going to be in the system for a good few hours. So we don't have to worry about that. But then we need to completely continue to repeat that every 15 to 20 minutes. And every 15 to 20 minutes, we're going to want to check the capillary refill. Personally, I would write it down, because it's going to be a very, very stressful situation. You may pass an hour and think that there's been no improvement if you don't time it and write it down, because you're in a stressed situation. But actually, it could have improved slightly. So I would write it down at every 15 to 20 minute juncture, and continue to do that process. You're going to have to keep doing that and keep doing it until it's fixed. And who knows how many vials, how many rotations of that protocol it's going to take. It could take hours and hours and hours, but until you can see that their capillary refill time has got back down to at least within a second or so of that original one that you wrote down before you did the treatment, you're going to need to keep going. Because the alternatives to that is to leave it. They end up with necrosis. They end up losing a part of their skin, potentially permanently. So, in my opinion, if caught quickly enough and treated in the correct way, they're really if people are set up with the correct instructions, the correct equipment, and the correct products, we really shouldn't be seeing cases of necrosis anymore.
It's all about the diagnosis when you are dealing with a VO and the time it takes to actually diagnose it. So what is really essential, and we highlight this when we teach as well, is to be available for your clients. So I know we did say, Adam said it earlier, about majority of the time it is going to be visible instantly, where you're already in your clinic and everything's available to you. But there are cases like that you've mentioned where people will go home and then they'll notice this, and like we said, if they're giving you videos or photos that are of a poor quality, obviously that's something that you need to take in consideration. Like, we've driven to people's houses before at way past midnight just to check to make sure that everything was okay. That, thank God, was. But if you aren't available on like a social media platform that they booked in, you don't give them like your personal number or like a contact number where they can contact you, and this poor client is trying to ring you and let you know that they have something that they are concerned about, then that does completely fall on you. So you have to constantly be available for your clients if there is a problem.
Yeah, 100%. And in fact, we do have an emergency vascular occlusion WhatsApp group, which I'll leave a link to as an invitation down below. And this is open to everyone, not just our students. Obviously, we have support groups specifically for our students. However, this is for everybody. So if you would like that little bit more support, then you're more than welcome to join that group. It's completely free of charge, and we will definitely help you. And in fact, the one time that I've had to deal with a vascular occlusion was not from us, was not from one of our students, but was from another company's student, and the company was up north and the student was down south, and I was basically asked to go and assist as a favour. So on that one occasion, it did take multiple vials of hyaluronidase to be able to actually treat that vascular occlusion, and that exact protocol that we've just been talking about was what I used, and that's what worked.
Yeah.
So it is proven. I've also seen it from other people as well where that has gone ahead and worked. So that is really vascular occlusion when it comes to mainly I guess we're talking about the lips. However, let's talk a little bit about different kinds of vascular occlusion in terms of diagnosis. So with the lips, we check the capillary refill. With the nose, we check the capillary refill. With the cheeks, we check the capillary refill. You can check the capillary refill everywhere. However, sometimes there is a vascular occlusion that appears to us differently to powness in the area that we actually injected. And that is whereby we might inject, for example, the nasal labial folds, and we end up with a bruise in our lips. We inject, hopefully no one is injecting with a needle, but we inject maybe around the medial canthus, and we end up with a bruise on our cheek, what looks like a bruise. Now, what that basically means is that if you inject in an area and you see what looks like a bruise in another area of the face, it means that potentially the product has travelled either backwards or forwards up the artery and has begun to block an area that is different, which then causes clotting in that area, which creates like a bruise-like look. If you see that on somebody, or somebody reports that back to you, you need to get into them ASAP. And if that happens, you don't treat the area where you injected, you treat the area where you're seeing the bruising, okay? Which is very, very important, because the filler is no longer at the area where you injected it. It's passed up through the different branches or back down through the branches to a different area, which is why we're seeing that kind of bruising, blanchiness in a different area. And it's very important to treat the area where you're seeing that, not the original treatment area. Very important. And if you see that, you need to address that very, very quickly, because it means that it's really gotten into quite a significantly bad situation. So that's very important.
And that's why it's so important to relay this information to the client themselves. So before the treatment or after the treatment, but I personally always do it before, because if your client doesn't know this and they do end up with a bruise around here and you didn't actually do any treatment in that area, then that's something that they might think, oh, this is normal, this is completely fine, just put some makeup over it and carry on their day. So it really is essential that you highlight this information to your clients before, and also they will feel safer knowing that you are concerned about these things, and like knowledge is power, and you feel comfortable with someone, and it's not just like quick sit on the chair and let me inject you. To have that conversation beforehand is essential and will make someone more confident throughout.
100%, yeah, so important. So that's a different way in which a vascular occlusion can present itself. So don't be completely stuck on the idea of blanching and powness. It can actually be a completely different presentation of the same problem. So if that happens, it's the same protocol again, exactly the same. Heat pack, massage, Viagra, chewing aspirin, continuously, hyaluronidase, on a 15 to 20 minute schedule. Do not leave it more than an hour before you start to retreat with hyaluronidase, because the half-life is 1 hour. So that is very, very important as well. And I think as well, let's just have a quick chat about how you try and prevent these things happening in the first place. And it all really boils down to one thing, and that is anatomy, facial anatomy knowledge. If you understand entirely your facial anatomy knowledge, it's going to set you in such a better position to be able to A, inject in the correct and safe areas in the correct and safe technique, but B, be able to diagnose and fix these problems afterwards and have a good understanding of exactly what is going on underneath the skin. So please do spend as much time as you possibly can, and in fact maybe we'll do just a whole podcast on facial anatomy.
Yeah, we'll do that next, because that's a really essential one.
Yeah. And we'll get the pencils out and we'll draw all over Annie's face. And we'll do a whole podcast on facial anatomy and what your landmarks are, because there's so many bony landmarks and other landmarks on your face that you can use to make sure that you're injecting in safe areas. For example, like the temporal crest, the gonial angle or mandibular angle, whatever you want to call it, the gonial notch or Manson's point. There's loads of different names for each one of these things. Even just understanding, for example, where your facial artery begins. So we always know that our facial artery is going to be, if you bite down, you've got your masseter muscle here, and it's always going to be around 1 centimetre in front of that, where it comes up from being submandibular and starts to work its way up the face towards the piriform region. So it's very, very important to understand your facial anatomy, understand your landmarks, and that's going to set you in such a better position to be able to go about and do your treatments in a safe way. And I think a lot of the problem is that on a lot of the courses that non-medics go on, they don't actually touch on facial anatomy. They just tell them where to inject.
Yeah, nothing to do with depth or anything like that. They just tell you where to put the needle and then nothing else. You can't expand from that.
I think best case scenario, they get a picture with the arteries drawn on. And the problem is, it really doesn't matter where in the face the arteries are. It matters how deep they are. So, you know, if we know, for example, that an artery is here, well, that doesn't really tell us where to inject or how to inject, because we still want to inject this area, but we just need to know how to do it. We need to know, like, you know, the facial artery is deep and then it starts to become more superficial. We need to know where the supratrochlear and the supraorbital arteries begin to become superficial and where they're deep. We need to know all of these different things in order to be able to inject safely.
We'll definitely cover this on our next podcast then, I think, and go into, like, proper detail.
The only problem is with doing facial anatomy on a podcast is the people that listen to it. I don't know what they would get out of it.
True.
So maybe we'll do it not as a podcast, but just as a separate video that we'll put on our YouTube channel, we'll put on our social media, but we won't make it like an actual podcast. Maybe that's the best thing to do. Yeah. But hopefully that's given you a little bit more understanding around VO. It is obviously something to be aware of. It's something to be ever so slightly nervous of all the time, so it makes you do the correct things and think about what you're doing all the time, but it should at the same time not rule your life. The chances of vascular occlusion in the lips are between 1 in 15,000 to 1 in 25,000, and like I say, the blindness cases are around 300 globally in the world. So you know, it's not quite as bad as we make out, but you always have to be prepared for the situation where it could arise. And don't forget that the cases of blindness that we've seen, they're not always because someone has injected in the nose or the forehead or the temples. There have been loads of cases where people have injected into the piriform region around the nasal alar triangle. There's even been cases where people have injected in the lip and the chin that have caused blindness, where the filler has travelled all the way up the different branches and worked its way into the ophthalmic artery, and as soon as it gets into there, you're in a very bad position. And in fact, they did lots of studies, and it turns out that if you have an occlusion in the ophthalmic artery that blocks blood supply to the eye, you have 89 minutes to fix it. Not 90, but 89 minutes. That was the actual study that they did, and it's 89 minutes maximum to resolve it. As soon as it goes from 89 to 90, you've lost either partial or full vision in that eye. So in the case where you believe that you've had an occlusion which has led towards the ophthalmic artery, you need to act very, 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 very quickly in order to be able to resolve that. But I think we'll talk about blindness and how to treat vascular occlusion, which could potentially cause blindness, in another episode, because it's quite a bit longer. So we'll leave it there for today, guys. Please do follow us or join our Facebook page, AA Aesthetics. I'll leave you a link down below as well for the emergency vascular occlusion WhatsApp group. Please only put in there ones that you think are, or you're almost positive are a vascular occlusion, and ask your kind of other support mechanisms, you know, the other questions before you get there. It is just an emergency group, but it is open to absolutely everyone, whether they're our customer or whether they're not our customer.
Yeah, 100%.
So do that, join our Facebook group, make sure you subscribe and like our videos on YouTube, and we will hopefully see you again within the next couple of weeks.
Bye guys.
See ya.